Hi, everybody. I'm not sure if it's evening or earlier where you are, but I'm in North Carolina and it is 5 or 6 o'clock, I believe. And I'm really delighted and happy to be here with you this evening. It really touches my heart to be a part of this and to reach out to my profession and my love and pride in my profession, and for all of the nurses all over the country who are dealing with such challenging and difficult issues. So I hope to be able to help you this evening with how to handle the pressure of the COVID pandemic and also take care of your other patients while that is going on. A lot is being asked of nurses and also physicians and in other disciplines right now. And I'm afraid we're kind of pushing everybody too far. We're pushing ourselves, which I know as a nurse I've done many times. So I'd like to just share a little bit of what brings me to this topic tonight. And one of the things I think is high on my list of innovation and has been for many years, actually since 1985. And at that time, I was working in critical care. I was also beginning work with burn survivors and the staffs that care for them at that time. And it was about maybe 6 years later that I started a private practice, which is almost solely grief and trauma related kinds of issues, people that have been through all kinds of things. But in 1985, I attended a workshop in Stony Point, New York. And that workshop was led by Elizabeth Kubler-Ross. And the purpose of the workshop was to bring together people who were either working with grief. We weren't paying much attention to trauma then, but who were working with grief and how to teach them to be supportive of the people they worked with. Excuse me. So that's what I went for. I went with my clipboard professionally there and was really kind of puzzled as to why there was such a wide range of society there. Doctors, nurses, hospice workers, yes, but also AIDS patients, cancer patients, people who had lost children, people who had significant other losses in their lives. So Elizabeth didn't believe in sorting or separating professionals and everyday human beings. She believed we're all human and we're all at the mercy sometimes of this pain of loss. And the best way to learn about that is to go through our own process. So I was totally unprepared for, nor was I even aware of how much grief I carried around in my being that went way back to childhood. And that workshop began a path of healing for me. But the other part of me, the nurse professional part, was also looking at all of these people who had lost people in hospitals or were dealing with tough illnesses, and how many of them carried unnecessary pain because of what was being done or said to them in the hospital by nurses, doctors, even social workers, people who were unaware of the impact of the process or even what they were dealing with and hadn't really been taught that. So at that time, I became dedicated to wherever I was working in nursing, that I would be teaching others how to help people with loss and trauma. That is, I have believed since 1985 strongly that needs to be integrated into our practice wherever you practice. So I think we have come a long ways with that. And I've seen a lot of changes with the COVID pandemic. An example would be, I see many nurses and many reports of nurses who are finding ways for their patients to say goodbye to their families. Because we know in all cultures that being able to touch the person, being able to say goodbye, actually actualizes the loss. So in my mind, that's a very excellent use of Facebook. that's not the way we would like that to happen. It wouldn't be what we would choose. It wouldn't be what our patients and families would choose, but it is what it is. So we have to do that well.
Yeah, it is what it is.
Because that is the beginning of the grieving process, when people hear the truth spoken with care and compassion. So, like I said, I have strong feelings about that. So Elizabeth's model, many of you may have studied it, starts out with people learning that they're going to die. That was a model that was actually written for dying patients. It was not written for grief and trauma in general, but it has been used that way. So people start out oftentimes in denial, and we're seeing a lot of denial right now in the pandemic. And denial is not just starkly denying that it's happening, but denying the seriousness, denying the impact, denying my responsibility to society and to other people when I don't vaccinate or wear a mask, those types of things. So it goes denial, bargaining. How do I get out of this? I think there are a lot of people still in bargaining, anger, and then despair, sadness, and then finally acceptance. I think that works better as a more continual circle process where we move in and out of those stages and we let go more each time. Like for nursing, I see one of the big things with the pandemic is many times letting go that I can stop this train that is the COVID virus. And I'm talking about once someone is in the hospital and they're being treated in acute care and critical care, and their respiratory compromised to the max and may not live very long, or may live for weeks or months on a ventilator and suffer. So that is grief for us, that we can't stop that. We have vaccines, so that certainly is helping, but then we have a whole populace who doesn't believe in any of that. So that gets complicated. The other problem with COVID is that, it's a threat to us as caregivers. It doesn't just threaten the patient and the family, but it threatens us. And it's one of those situations where the more you know, the less you have the ability to deny. So I think I try to have compassion for people who are still in denial that there is a pandemic or that wearing masks helps. They obviously haven't taken microbiology or seen the working end of this virus and what it can do, or know how dangerous it is. So we have to find a way to continue in compassion, as is in every nurse, I believe. Sometimes people in nursing and medicine, I have seen, will kind of harden their heart to the loss issues. I'm going to put a cough drop in my mouth here. I've been kind of struggling with some asthma all day. I did have a COVID test yesterday, which was negative, and happy about that, but still makes it a little challenging to talk to you. So that denial, bargaining, anger, and then moving towards despair and acceptance. We're seeing that process move very quickly through patients and families. They just don't have time. Many times we call primitive cultures, which actually doesn't mean undeveloped. It means our original nature. Cultures where people wail and cry, or lay on the body and hold the body and cry, we think of that as out of control. I see that as in control. When I worked as a psych CNS in a large acute care hospital, I was referred a lot of patients and families who were out of control because they were so in the initial stages of grief. But if you think of that initial point in grief as the place where the healing process begins, and if we do not give people the truth in a compassionate way, we block their healing process. If we don't help them say goodbye, it blocks their healing process. if we give them false hope, it blocks their process of healing later on. And I'm all for helping people hang on to hope, but I'm also for saying we're all doing the best we can. We're not sure where this is going to land yet. We are here for you for the duration. So, and that you're strong, you can do this, but there's a point where we have to say, we're kind of losing the war here. And we need to help you say goodbye to your family, because that's the most important thing on the table. So we as Westerners just don't think that way. We like to think we're in control of death. I can't tell you how many physicians I've stood with in the hallways out of peds ICUs and other ICUs. Oftentimes as a young resident, and he might even allow himself to cry and say, I should have been able to stop this. I should have been able to do this. And we have only a limited amount of control over death. We do have control over the process of healing when we learn how to facilitate that. So I wanted to be sure to mention that, because I think this COVID pandemic has a lot of loss in it and a lot of grief that goes along with that for staff as well as families and patients. But it also is a trauma that threatens all of us. So many nurses are literally working in MASH units. Thankfully now we've gotten on the bandwagon having adequate PPEs for nurses, not only adequate, but exceptional protection for them, when that wasn't always so in the beginning. And now we're seeing our second wave with the Delta variant. And I'm sure all of you are aware that this virus is very wily and it mutates again and again, and that we are its host. So people who aren't vaccinating or masking are giving this virus time to mutate. And so it's really hard not to be in a place of anger and frustration with that. Ori, if you could put up my first slide there, Ori. So grief is mostly going through that natural process that is built into us to help us to heal. My work is helping people access that process and to help it to move. And that means creating safety for feelings. It means being a non-judgmental with feelings. Okay, there we go. So grief will move on its own unless it becomes complicated by trauma. And that's what I wanted to focus on mostly here this evening. So you've got these two processes, the grieving process, and then also what happens when we are traumatized. We have the brain of a mammal. I know we like to think that we are the highest, wisest critters on the planet. I doubt that sometimes. But we do have the brain of a mammal, and it reacts to trauma as every other mammal does. You know, our neocortex and cortex will shut down because we're moving into those intense feelings of trauma from the limbic system, and then also our old brainstem, reptilian brain, whatever you wish to call that, also takes over because of the threat. So within that reaction, there's basically a limited number of reactions we will have because we're not thinking, because we're not responding from a rational place many times. The first is fight, and I'm sure you have all heard this: fight, flight, freeze, and surrender. But I'd like to look at that behaviorally and what that looks like in both your patients and families, but also in the staff, in the nurses, the doctors, sometimes even your families, your spouses, your partners. So fight can look like a short fuse, quick to anger, irritable, risk-taking behavior, hyperactivity, defiance. I've worked with a lot of traumatized children over the years. I've worked extensively and continue to with burn survivors, both pediatric and adult. And they have taught me a lot, since that's a, very severe trauma, as we all know. Not that it's the worst. I think it's all the worst, to have that level of physical, emotional, and psychological trauma. And the same is true with COVID. So if you see yourself in those symptoms, irritable, angry, short fuse, taking risks, flight can oftentimes look like social withdrawal and isolation, not wanting to call a friend to go out to lunch or talk on the phone or do a Zoom call or some other way to stay connected. Avoidance of connection in general. And I've also seen many people who do a geographic flight away from their trauma. In other words, they can move from one coast to the other in this country, and the trauma symptoms still follow them. But it is an attempt to run away from it. And then freeze, which is becoming immobilized, numb, withdrawn, overly compliant, denying needs. We as a profession are very good at that anyway, denying our own needs, and we have to do a better job of that. Also, freeze can look like a stilling of behavior, and that can be true with children and adults, where there's the hope that, if I just stay still enough, this threat will go away, and then surrender, which is moving more into helplessness and assuming the victim role. Like, I give up, there's nothing I can do. If you think about, I used to have this great cat, Calvin, and I just loved him. He was a blue Russian, beautiful guy. And he used to bring me mice, birds, any little thing he could catch. And he would bring it to me and lay it at my feet. And as soon as he was out of the way, the little creature would, start shaking or maybe move a little. And I would take them outside and protect them. And they weren't dead, they were in freeze. They were avoiding the predator. But our brain works the same way as human beings. Our brain doesn't know if we're being chased by a tiger or threatened by this virus. Our old brain interprets that the same way because it's about survival. It's about getting us away from. So somehow as nurses, we have to figure out, how do we override that response when we're working with really difficult situations like COVID, and where COVID is threatening us also and our families. Most nurses I talk to who are working directly with COVID will tell me they're so careful about their families, and sometimes they don't want to see their children or have any direct interaction with them out of fear that they're going to, pass this on to them, even if they may be asymptomatic. We can go to the next slide, Dory. Okay, so let's talk a little bit, because this gets thrown around a lot: PTSD, post-traumatic stress disorder. First of all, right after trauma, most people will respond with some trauma symptoms. It doesn't mean they're diagnosable with PTSD, but what you hear is, so somebody's irritable or they're snapping at people, and someone will say, oh, they have PTSD. Not necessarily. In the first place, in the face of threat, we may develop an acute stress disorder, which is diagnosable up until 8 weeks after the trauma. And then we give the diagnosis of PTSD if people meet criteria for PTSD. So these are some of the things that, I'm stepping out of the DSM-5 here and trying to help you look at this and look at yourself as a human being. So I'm not using psychiatric jargon on purpose. Plus, I've learned it doesn't necessarily help people. It's more connecting with people on a human level that helps them. So obsessive thinking, how many of you, or how many of nurses who work with you can't stop talking about COVID, thinking about COVID, trying to solve the problems of COVID, even become paranoid, they're angry and perseverate about people who won't get a vaccination, people who won't wear a mask. And here where I live, where there's, how would I put this nicely? There's a certain population that have made this such a religious issue, a political issue also, but also a religious issue, where you're seen as not having faith if you're wearing a mask, or if you're asking people, why aren't they vaccinated, that type of thing. So that makes that threat of COVID even more ever present in our lives. So compulsivity, impulsiveness, risk-taking, erratic behavior, isolating or perfectionistic behavior is common as well as a trauma symptom. I learned early on to be as concerned about the child who was acting out and was hyperactive and taking risks, to be as worried about children who had become perfectionistic and they were reading all the time. They were helping their parents. They didn't want to upset anybody. That's another way of expressing a reaction to trauma, which isn't necessarily helpful because it does not deal with the trauma. So like the little bird or the mice, if you followed most mammals who are traumatized into the woods after a trauma, like a deer being chased by a dog, that type of thing, you'll see them stop and shake off, physically shake off the trauma. I've seen some people do that, but we tend to want to override that because it embarrasses us. And I've worked with EMTs who will tell people, you need to stop shaking, you need to stop doing that. And my brain is saying, don't get in the way of their process. Let them go through it so they don't get stuck in it. Difficulty regulating emotions is a big one. Some people will say, I just can't do it anymore. All I do is cry. All I do is feel angry and irritable all the time. And so emotions can be very intense. And then sleep disturbance, depression, anxiety, those are all symptoms of post-traumatic stress. The next slide, Dory. Okay, and then other symptoms, of course, are substance use disorders, drugs, alcohol, other ways to have addictive behavior, whether it's sexual addiction, exercise addiction, work addiction, where we're trying to get away from the pain by going really fast. Eating disorders, anorexia, binging, bulimia, oftentimes have their beginnings with a trauma. I have worked with many adolescents, young 20s, who were traumatized as children, physically or sexually, and don't have recall of that, but their symptoms are expressed in an eating disorder. So problems with intimacy, abusive relationships, inappropriate control in relationships, and difficulty with boundaries. So those are all ways to look at kind of the human impact of trauma. We can go to the next slide, please, or okay. I've done I took a drawing therapeutic arts methods class many years ago with a Jungian analyst, which was very interesting. But then I started using drawings when I was working with people who were traumatized and when I was working with groups who had experienced trauma. So this is a drawing that I have seen over and over and over in that population. And what this is, and this is just one example, and I use this with the person's permission. But you notice the heart is like bright red, kind of intense, but in the center you see this black hole. That's what happens with trauma when it's not helped to move and heal. So I always see that black hole as disconnection from the self, however you define that. So I would say probably ultimately we're talking about spiritual connection and connection to life and to others and to people that are important to us. And eventually there was a man from the Oklahoma City bombings who talked about his PTSD. And he says that PTSD is like cancer. If you don't treat it, it will destroy your life. And it will also become a depression, which I totally see that and believe that he's right about that. So those are, I'm really sorry about my voice, guys. So the other things with COVID that make it difficult is I've been with a lot of dying patients from very little to the elderly. And COVID, as I have read about and heard nurses talking about, is a very difficult death to be a witness to. So it's not like having somebody who is 80 or 90 years old and it's their time to let go of their life and say goodbye to their family. It's a horrendous death, or can be. Most of the time it is. So, those are more difficult for us to witness that death. I always thought of it as a real honor when I was doing that work directly, to be with people at the time of their dying, of their time of letting go. For me, that was always just an amazing, special privilege. So you have to really learn, to look at your patients in this way, like this heart, helping them stay connected, helping them express their feelings, helping them Skype with their families or Zoom or whatever, platform they're using for that, to help them stay connected. I think with children, helping them to draw the problem or draw the trauma helps them to move that process. In essentially, they're in the process of shaking it off. And the more severe the trauma, the longer it's going to take to recover from that, if we ever fully recover. Because anniversary dates, say this time of the pandemic, that will be triggered in time, over time, in our lives, and it'll come back up to be healed at a deeper level. So I don't see that as something's wrong with what this person is doing, or that they aren't healing, or they're doing this wrong. I don't look at it that way at all. Okay, let's see. Do we have any questions in the chat that we need to address? Ori?
Megan, there was a question in the chat. It came from Steve. He popped into the chat. He's wondering about prolonged trauma over time as it's being experienced, and what are those effects on the brain and body?
Yeah, thanks for that question, Steve. That's an excellent question. Well, and I think we see that with COVID. For the nurses, it is repetitive trauma, and physicians and people working with the patients, and probably even the housekeeping personnel, anyone who's around that for 12 hours at a time, sometimes 4 or 5 days a week, that repetitive trauma gets embedded deeper and deeper into the brain, and will be harder to overcome. One of the things I highly recommend is EMDR. I movement desensitization reprocessing. See, I trained it and I can't even say it. But that is something that is very helpful for chronic PTSD or repetitive trauma PTSD. So we're not talking about here single incident trauma, which is usually resolved fairly quickly, unless they have a trauma past. We're talking about the repetitive trauma and the horror of what we are witnessing, and the sadness of that, and the fear that triggers in us of not wanting this virus to, visit us. So I think it's really important to take care of ourselves with that too. But EMDR, in 1995, I believe, I was first trained in EMDR and began working with that with people that I had worked with for years who were dealing with trauma and complicated mourning and grief. And those studies just came out. Bessel van der Kolk was talking about them in Chicago at the time. And the studies were, they had a control group that was, of course, did not have an intervention. They had a Prozac group that had the intervention of fluoxetine regularly for 6 weeks. And then they had the EMDR group, the group treated with EMDR. And what they discovered across time of the study is that the Prozac group at the end of the study became symptomatic again, requiring more Prozac. The EMDR group improved during the study, but actually when they stopped the EMDR, the patients continued to improve. So I don't even think there's a logical reason yet, though we'll get to that at some point, why that works. It's now the first line of defense against PTSD for our combat veterans and many other types of traumas. CBT, cognitive behavioral therapy, is also very helpful with chronic PTSD. But the thing I like about EMDR is that you are using mind, body, emotions, cognitive. All those levels are involved in that modality. So it's really a holistic approach. There are many other approaches that use the wisdom of the body, yoga, Tai Chi, and many other, somatic treatments. But I don't think that they have proven, and there's a lot of research that's been done on EMDR that proves its efficacy over time. And what I saw in my patients after I was trained in EMDR, what I saw in them is people I've been working with for a number of years. We do a few EMDR sessions, and then I'd be getting a call saying, I need to cancel my appointment. Tomorrow I've got get my resume together. I've got some job interviews. And I'd be like, yay, that's what we want to hear. I don't care if you're a nurse being the therapist or some other type of discipline. The measure of good therapy is not what happens in the room with the therapist. It's what happens in the person's life. So that's how I look at it. So I hope I answered that question. That sometimes repetitive trauma and chronic PTSD require a longer term approach. And medication is often part of that. And you'll run into a lot of people who are anti-psychotropic meds. 12-step programs are kind of, known for that if you're taking an antidepressant, then that means you aren't dealing with your stuff. You're, just taking another drug to get rid of the other drugs. And, that is a position of really not knowing the theory or the chemistry, the neurobiology behind psychotropic meds. So that's another whole story. Are there any other questions?
Yeah, Steve said thank you for that answer. And I have a couple of people with hands raised. Just to kind of go through we'll have a question and answer period with Megan. We're going to transition to Allison, who is from the American Nurses Foundation, and there will be a question and answer period, and then we'll open it up to the group to have a conversation. So feel free to send any questions that you're not comfortable, adding to the chat. You can send them to me directly to the innovation moderator. Those will remain. We can keep those confidential, and happy to share those. There are some comments in the thread. Megan, Mina shared a text message with the group about meditation, deep breathing, sleeping have definitely, helped take the edge off that anger, grief spectrum. So parallels a lot of what you were already bringing up, and some good discussion about spaces within within organizations, departments, facilities, respite rooms, and different places where staff and individuals can decompress and just have some quiet before returning to direct care.
Yeah, and I'm so glad that we've evolved beyond what I dealt with many times clinically. I remember I marched into the CEO of my hospital's office unannounced, without an appointment, and he was very attentive because I was upset. And all I said to him is, I have met with the last family who are dealing with their initial grief in the bathroom outside of ICU. We have got to have a grieving room that is dedicated for staff or for families when they're in feelings, that they don't have to feel like they're doing something that they should be ashamed of or have to hide. So I've certainly seen us come a long way with that journey.
And a few more comments coming in with that. Also, there is a comment from Bev Nuremberg, and I just want to make sure, give me 2 blinks here while I'm scrolling through our messages here. I just want to make sure I share it correctly. Evidence, Bev Nuremberg shared a comment with a group, remarkable evidence-based energy healing techniques, and how that is being used based on 5,000-year-old acupuncture. So just some other, and how that impacts the parasympathetic system. So any thoughts around some of those? And it sounds like it's being used by the Veterans Affairs for PTSD as well, and as well as some larger systems like Cleveland Clinic and Kaiser.
Right. And I've worked quite extensively with a energy touch school in Michigan, and have seen what can happen when someone is attentive to helping to move the energy of that person or the chi in a positive way, whether you're doing that through Tai Chi, through therapeutic touch, through many of tapping, many of the modalities that are just exploding around us. I think it's going to give us direction on, ways that people can be helped more efficiently, like I was saying. And I certainly welcome all of those modalities, except I do like to see some evidence-based discussion about that and research, because there also are some things out there that I consider dangerous, and that should be monitored by somebody who understands medicine, and or by a nurse. So you have that side of the coin too, kind of people that are coming out with, we used to call them new agey. I don't like to do that because that's really labeling a whole group of people. I guess I would call it more arrogance, somebody who doesn't have the training, doesn't have the theory, and they arrogantly are telling people, don't take your meds, don't get your cancer treated, we can just do this. Cancer treated by medicine, Western medicine, we can just do this and you'll get better. And so I think we have to be careful about those things and make sure that they're grounded in fact and grounded in time, and that they're safe for our patients and ourselves.
And Megan, there's one other question that is kind of a comment talking about trialing a hot debriefing tool from Tasha in the chat, talking about how to support nurses emotionally after adverse events to lessen the impact of second victim phenomenon.
Mm-hmm. Yeah, and I think debriefing is a good thing, but I think you have to wait, either do it ongoingly, especially in a COVID situation where the losses and the traumas keep coming at us. And to not do it too close to when the trauma occurred. Like I've worked a lot with first responders, firefighters, some with peds intensivists, for example, and other disciplines. And, sometimes they want to push the process. So, excuse me. So they push a debriefing too hard and too fast, and they don't know much about creating safety for feelings and safety for the process in a group. They kind of want to tear the Band-Aid off, so to speak. And, so I want to put some caution out there about that, is not pushing the process, but allowing the space, certainly. And I think that has to be in every hospital anyway, and many other settings where nurses work and doctors work. And that is places for them to be cared for and have support for their feelings and support for their recovery, where they don't have to think that they have to be tough in order to be a good nurse or a good doctor. And I worked in critical care and in burn, so I understand what it feels like to be a jock nurse, and that's what we used to call us when we pushed ourselves too hard for too long and didn't see our own humanness. So if we could go to the next slide.
There. Here we go.
Did you have something else, Ori?
There are a few more comments. I just want to let people know I'm trying to stay on top of comments, and we'll loop back. But some great discussion happening in the chat. So
Great.
Please go ahead, Megan.
Okay. This is kind of a model that I developed trying to come from a holistic place. Although of course it is, doesn't have the dimensionality that a whole person does, but that we aren't made up of parts. We are made up of aspects of ourself that interact with one another. Those are physical, of course, emotional, intellectual, social, and I think of the spiritual energy, or whatever you call that life force energy that is in us, that runs through all of those aspects of ourself. So I'm just trying to give you a visual of how I think about that. And so the challenge is finding balance within ourselves, and first of all, finding the center of oneself and coming from that place, but also looking at ways to maintain our physical health and balance, our emotional health and balance and ability to regulate emotions. And of course, that's all embedded in a social field as well. And then the intellectual or cognitive. Now, our culture pays a lot of attention, now I'm talking about Western culture, pays a lot of attention to the intellectual and the physical, that we don't give the same energy and attention to the emotional, the social, and the spiritual. So, and again, I'm not talking about religion. I'm talking about however you think about that, whether it's nature that helps you connect to that center of yourself, whether it is sitting by a lake, whether it is being with your friends, whether it's going to a church community, whether it's a 12-step meeting, it could be anything, whatever helps you to take a deep breath and sigh and say, I'm still here. But the way we are being pushed right now during this pandemic, has that risk of disconnecting us from ourselves. And that's why I am so grateful to all of you for the work that you do, and very proud of nursing right now. I always have been, but especially now. And that we apply these types of models of healing to ourselves and to our peers. and that we make space for that, and that be okay. That I think I mentioned this to Ori last week, that we have amazing instruments in the hospital that we use, amazing technology that we're using now. I was in an ICU recently, and the thing that came to my mind is, my gosh, these machines have sure multiplied and multiplied, but they're so specific and so helpful in giving us data. But we still need to look for, where is this patient at in their being, not just the monitors, the vitals, etc. But to make a space for that. So thank you, all of you, for the work you're doing. You are incredibly important. And I personally don't use the term healer about myself, though people say that to me. I always kind of cringe, because I don't want to have my work become about ego. I really watch that. I have a friend who says, if she feels like I'm falling into that, where people are giving me their power, she'll say, I'm going to break out those Mega Moonbeam t-shirts and we'll sell them. So I know that means that I need to come back to my myself and stay connected. But thank you again for all you're doing. And I think that this is a good point to move on to Allison. Ori?
Absolutely. So just a couple of quick questions, and I think this will transition and bridge into Allison as well. But just thinking about, and we'll save this for both speakers at the end, but ideas for winding down after a stressful shift. How do you care for people and not take on their frustration and grief? Also some questions about trends, which I think Allison will also be able to delve into a little bit. So I am capturing those questions, but excited to open the conversation and introduce Allison Norberg, who is our program director at the American Nurses Foundation. Allison has been doing incredible work with the Wellbeing Initiative. She has over 10 years of experience in program management, and with her work in the Wellbeing Initiative, I can tell you she has passionately driven that work forward. So I would like to welcome Allison to the group, and thank you very much, Megan.
Thank you, Ori, and thank you, Megan. Or you can go ahead and bring up my slide. I think what so nicely ties the work that Megan is doing and the focus that she brought to, especially at the end, of you as an individual, how do you take care of yourself? I think where we'll tie together is the focus that the American Nurses Foundation, as part of the ANA enterprise, really brings into both the organizational focus on how do we support nurses' well-being during the pandemic and beyond, but then how do you bring that as an individual into the space as well, and ensure that you're taking care of yourself. One of the interesting things that I've heard very consistently, even at some of the early focus groups from nurses, was their desire to bring mental health and well-being programs. When we presented programs to them, they first thought was often to bring them to their patients. And this was an opportunity for us to really say, no, this is where you need to be for your recovery first. And so I want to premise and really focus us at the start of a framework that the American Nurses Foundation has been using during our work around mental health and well-being and in other places. And it's interesting that innovation has the connection to renew, because these are also 3 R's. So this is around relief, recovery, and rebuilding. And so all of the work that we've done fits into at least one of these areas. So initially providing relief to nurses was getting information and tools into nurses' hands as soon as possible and as quickly as possible in ways that could be implemented almost immediately, whether that be access to call a warm line or to have access to an app to help them think about their breathing, which I know was a comment that came up in the chat earlier. Then we move into the space of rebuilding, or of recovery, and that is, how do you increase strength and resilience as nurses come to terms, and as Megan was saying, around the trauma and the grief that they have likely experienced during the course of the pandemic. And then we move into that space of rebuilding. And this really is the long-term work of how do we transform the structure and culture within nursing and healthcare at a larger level, so that we don't go back to the pre-pandemic way of being, if that's even possible anymore, but really make that larger transformation that really focuses on how are we lifting up the mental health and well-being of all nurses. So next slide. And so we have seen so many examples of innovation during the course of the pandemic, and that's the same in the mental health and well-being space as well. But we also faced a number of complexities, within that, really at the beginning of the pandemic, but then even as we continue now. And so early days, we were building the airplane and flying it at the same time, as so many others were doing. And we knew that nurses were in need. Prior to the pandemic, we knew that rates of burnout were between 30 and 50% of nurses. About 12 to 20% of nurses had experienced some type of PTSD during their careers, and yet we still were facing challenges, and we knew that we needed to be able to address them. And so the first challenge that we faced was the immediacy of the need. The pandemic started, and we knew that there were going to need to be tools and resources put into place. And how could we do that in a way that was evidence-based, and we knew we would be promoting quality tools. The second was a lack of time. This has come up over and over again when we talk to individual nurses, when we hear from focus groups, and then this is also validated even most recently in our most recent mental health survey. It's consistently the top reason why nurses say they have not sought professional mental health support, that they don't have the time to do it. And then the third challenge is around the volume of tools available. Early in the pandemic, very well-intentioned organizations put out lots of resources. They web pages of links upon links upon links. And so for an individual nurse or a nurse leader who's looking for resources for their teams, going through all of that contributes to that lack of time and that information overload. And then finally is encouraging people to use the programs themselves. That we thought originally, maybe naively, that this would be a little bit of a field of dreams. If you build it, they will come. And that really, in some cases, has been true, but in a lot of cases, and almost every single different partner that we've spoken to, the programs that have been put out have, in a lot of cases, not been utilized as highly as we're seeing the need out there and the interest from nurses. And so it's connecting, how do you go about actually getting people to use those programs? So next slide. And so we were very strategic and intentional in how we could go about addressing all of this. So we designed and focused on some key principles and approaches to help us think through how we would go about providing programs that we knew were going to be of high quality and used. And so starting with this is consulting the experts and advisors. We knew we needed to bring nurses together. All of the programs that we have are all nurse-led or nurse-advised. And we know that that was critical because nurses trust other nurses. And so we wanted to have those so that we could then create evidence-based or invest in evidence-based programming. And then additionally to that, what is so important is to leverage and invest in partnerships. And so one way that those partnerships look is our Wellbeing Initiative partners. And so that's in addition to ANA, it's also the American Psychiatric Nurses Association, the Emergency Nurses Association, the American Association of Critical Care Nurses, and the American Organization of Perioperative Nurses. And so we focused on collaborating with these groups because their members were most directly impacted, at least early on in the pandemic. And so they had not only the access to those nurses, but also the expertise to be able to provide insight into what those nurses needed most. And it also enabled us to reach larger groups of nurses. And then we also partnered with other organizations that could, in some cases, help us make some small changes to existing tools and resources to make them nurse focused so that we could get interventions and resources into the hands of nurses as quickly as possible. And so that really is around prioritizing those active interventions. And so for us, we really wanted to, at the very beginning, start with a focus on safety. The first tool we put out was how to go home, and as Megan said, at the end of your day and do as much as you could to not bring the virus into your family. And then over time, we've been able to expand. So we then expanded to programs that provided access to warm lines, apps that would be helpful. And then slowly from there, as the pandemic continued and as we were able to address some of those immediate needs, expand into more recently a program focused on how to cultivate gratitude, because there is so much evidence around the connection between practicing gratitude and the benefit to your well-being, as well as tools around how to think about and how to process grief. And so all of the tools that we've also provided are intended to be as multimodal as possible. We know that everybody processes in different ways. And if we were going to just provide one set of tools, that really wouldn't be reaching the broad range that we want to. So for a nurse who wants to speak with somebody, we have that access. For a nurse who wants to write about it, we have programs available. And then for somebody who doesn't know where to begin, we also have programs available. And so that really was very intentional in wanting to be able to engage as many different nurses in as many different ways as possible. And then on top of all of this is how we can leverage communication structures. So I mentioned that we have a large partnership across ANA, our Wellbeing Initiative partners, and then so many other, probably many of you on this call tonight, are able to disseminate this information. And that really has been the crux of how to engage nurses in this content. We've done, in addition to the traditional social media and things like that, we've realized that there's the importance of paid social media. We've seen the importance of engaging nurse influencers because, again, as I said earlier on, nurses trust other nurses, and when they're able to share that through their media and their channels, that's really how you can get to engage a wider audience. Next slide. And so what has come about from this is the Wellbeing Initiative. If you're familiar with Healthy Nurse, Healthy Nation, another program within ANA, they have 5 different domains, one of which is quality of life. And so the Wellbeing Initiative fits within that space of quality of life, but is intended to also stand on its own, highlighting just how critical mental health and well-being is during the pandemic, and then continues to be, of course, but wanted to be able to have just a very apparent pillar and resource for nurses to be able to access. And when you go to the Wellbeing Initiative website, you can see it's relatively sparsely populated because we are trying to intentionally focus on what are those key resources that we provide. And so each of these different graphics highlight one of the different programs that we have been using throughout the course of the Wellbeing Initiative. So you'll see we have, as I said, multimodal programs. So there's a writing opportunity, there are opportunities to speak to each other, there are apps to help you focus on your breathing, and then there's also, we've done some workshops, and that really has been intended to reach as wide of an audience as possible. Next slide. Because so much of this has all been driven by looking at the data. We want to understand what nurses need, what they want, and what they inevitably are also using. So we looked at the Wellbeing Initiative data, and one of the easiest things to do is to track the usage. So we've had about 63,000 nurses use at least one component of the Wellbeing Initiative. And intentionally, when we built the initiative, we wanted this to be interventions that would be fairly short interventions. Most of them take under about 15 minutes to use. Some of them, the workshops do take longer, but then also they were intended and built so that they could be largely anonymous, because we knew that that was another factor for a lot of nurses. One of the challenges that that brings about is that it's harder to track the longer term impact that these programs are having. And so that's something that we are looking to continue to evolve and innovate in our future work that we're doing, but we are able to pull out some key places where we know these programs are having an impact. So there, the narrative expressive writing program, for example, we have seen about a 10-point decrease in self-reported perceived stress levels over the course of that 5-week program. Our compassion and growth workshops, which focuses on post-traumatic growth, about over 90% of nurses who took that program are still continuing to use some of those practices today. And so those are really encouraging look at some of those individual programming aspects within the Wellbeing Initiative. And then on top of that, at a larger scale, we have the Pulse on the Nation's Nurses Survey Series. And so since about April of last year, we conducted 10 different surveys, had over 120,000 responses across those surveys, and we focused on a variety of different topics that really have enabled us to hone in on what are the needs of the nurses at the moment. And so we've done now 3 surveys based on mental health and well-being. The most recent survey just wrapped up a few weeks ago. We're in the process of getting the final analysis of that. But looking back to the survey right before that, we saw, unsurprisingly, about 50% of nurses were exhausted, over 43% were overwhelmed, and then 24% of nurses had sought professional mental health support during the COVID pandemic. And if you remember back to the very first slide, the #1 reason that they had not was because of the lack of time to do so. And earlier in the chat, I saw someone mention a question about how to support younger nurses. And this really is where we see a huge difference between the more seasoned nurses and either nursing students or novice nurses. While they are more likely to have sought mental health support, the not understanding or not knowing where to get the support that they need is actually it shows up more prominently amongst nurses under the age of 34. So that's one way to think about how can we reach younger nurses, is how can you help them understand where to get that information, whether that be from your employer, from an association, or out in the community as well. And then the final data point that we had from the survey that was conducted back in January, February of this year was that about 18% of nurses had said that they were intending to leave their position within the next 6 months. And of the top reason why, it's because work was negatively impacting their mental health and well-being. And so that right there is incredibly telling and really important for us to think about, what do we do into the future? So next slide. So because we need to be continually looking into that future, we are continuing to offer the programs that are focused more in that traditional relief space. But what do we do now to prepare for that rebuilding? And so for the foundation, one of the pieces of data that we've looked at is about 1/3 of nurses have said that they experience some type of stigma within mental health and well-being. And so that is then related to our desire to work on addressing this into the future, because we know that stigma is something that nurses don't experience as an individual in a vacuum, but there are so many other places where that comes in. There's the individual, There's challenges within the employer. It was wonderful to see how many people have been able to access respite rooms, but there are a number of other challenges involved with that. And then there's, of course, the policy involved around licensure, that's an issue that we hear brought up fairly frequently. And then, of course, this all fits under the larger umbrella of stigma within mental health is something that is experienced across wider society. And so this is an area that we're in the process of working on now. And we know that this is where innovation and new thinking and new programming is going to be so incredibly important. We are hoping to be able to offer programming that would be able to reach an individual nurse as well as support their organization in order to encourage more nurses to use programming, and then specifically ways that will address stigma. And then also supporting that role of the nurse manager. If people have seen the AONL most recent longitudinal results, that has been an area of large concern, the nurse manager role moving forward. And so then on top of that, there's the issues of policy and how do we address concerns around licensure? And then how do we encourage nurses to play that role as the destigmatizer within that wider society? And then in that long term, how do these all fit together to make that lasting impact? So next slide. So that really wraps up my part of the presentation. I don't know whether there are questions, but both Megan and my email addresses are here. I certainly would love to hear from anybody who has new ideas, particularly related to mental health well-being programming, stigma programming as well, but I'm happy to answer any questions as well.
Yeah, Allison, I just wanted to loop back to some of the resources that you shared. Are all of the resources that are being created by the Wellbeing Initiative, can you talk about the accessibility and cost or anything related to any of those resources?
Absolutely. So those resources are all available on the Nursing World webpage, and I'll make sure that that gets dropped into the chat. They're all available for free to anyone, regardless of ANA membership. You do not need to be an ANA member. They're all in front of the firewall, I guess to say, and they are all covered by the foundation and generous donors that we've had, because we do not want that those pieces to be holding back from being able to seek that support.
That's such a huge resource. Thank you. So just looping back to some of these questions that came up in the chat, there was a question around, you talked about and you shared a lot of the resources, and so did Megan in the impact of some of the, these practices on our mental health and wellness. Winding down, so this is a question that came through to the moderator, winding down after a stressful shift, how can nurses, as they're doing this work, not take on the frustration and grief that they're experiencing in the workplace? Any resources or thoughts related to that one?
I have a thought about that, Ori.
Please jump in.
And that is, it was one of the things I didn't complete my thought about the beautiful instruments and technology we have, and we take very, very good care of it. And I think what's innovative and exciting for me is to swing our attention and focus to taking care of nurses, who are the most important instrument in any healthcare setting, in my opinion. So just to see that focus on helping them is very exciting. And I wanted to mention, in terms of the grief, it's something that I learned early on, and I became a member of Elizabeth's workshop staff and traveled all over the United States and different parts of the world. And that's where I really learned so much about grief, was doing that work. But one of the most important things I learned is Elizabeth was very hard on her staff. She used to say, if somebody was bugging you, a participant at the workshop, and kind of getting under your skin or irritating you, she would just look you right in the eye and say, do your own work. but she would say, do your own work. She was a Swiss, she had a heavy Swiss accent. So if something comes up for you while you're working with grief and trauma, you need to connect with that later when you get home, or have a moment to yourself, journal, ask yourself, there's a lot of grief moving for me. What did that patient situation or family situation touch in me? There's a difference between having your heart touched with compassion, or even having tears when your heart is touched with compassion. But when you step across that line of feeling like you're taking on someone else's grief, something has been touched in you that needs to be addressed. And that's why I would see the support groups for nurses ongoingly, confidential groups where they can, look at themselves and get that out of the way so it's not contaminating their work, whatever their issue is. So that was not seen in the work I did in the workshops. That was not seen as a negative. I came from nursing medical training, where you had all your stuff together already, so you weren't allowed to have a process. In other words, if your heart was touched, or you were feeling grief, then it meant you weren't strong enough. So sorry about my voice tonight. So I just wanted to mention that in terms of not taking on grief.
Mhm.
And also processing the sadness we feel for the position our patients are in and families are in. Keeping a journal is a wonderful way. Creating a peer group for nurses that can talk about these things, and just know that the way you're processing will make you a better and better and better nurse, because that won't be under the table getting in your way.
And Megan, there are some comments in the chat about grief share support groups. And Steve shared that he is starting a group home and hopes to, there's also some animal therapy. Steve wants to kind of integrate equine and horticulture therapy. So there are definitely we have some innovators and some creative members in our audience who are looking at different ways to bring that in new ways of thinking and self-care to the profession. And with that, there was also a question that was sent forward in the chat around some of those trends. And Allison, I think this is probably for both of you, but one of the comments earlier was around kind of looking at some of those suicide numbers that have been shared and increasing. The person commented that seeing men aged 50 to 65 are having increased, they're seeing an increase in suicide, and how that is impacting and adding additional trauma for families navigating the pandemic. So any thoughts around some of those numbers or trends that you might be seeing?
I think that, making a broad statement about suicide, that generally you would be having somebody who is in despair, who is without hope, who doesn't see the point in going on, or they've lost so much they don't see the point in going on. So our job is to help them connect with themselves. And I think we find hope when we connect with others. So again, groups are a wonderful way to do that. I think we've been doing that with oncology patients and even outpatient oncology centers for a long time, but now we're talking about moving this into the general population, whether it's COVID, which is, I think, a very difficult challenge grief-wise, because you have that combination of grief and trauma, and how do you help people get through that? And I think sometimes it's, a life ring. I've worked with many people over the years who have told me they were without hope, that they had a child die or some other really tough thing that happened, and that they had no hope and no reason to go on. And sometimes I'll tell them, you know what, for right now, I'm not trying to rescue you, but I'm going to carry the hope for you. And we're going to help you pick that up. You can have hope again. So you see, it's instilling hope is very important.
And I just add too, there is a body of work within ANA. There's a Strength Through Resiliency committee that was created in 2020 that is focused primarily on the issues that are connected and related to nurse suicide. And so I'd encourage, I'll put the link in the chat right now, and encourage people to take a look at that as another offering and resource.
That's great. Thank you.
Thanks for sharing that, Allison. And there is a question that was also added to the chat. So we have some and some messages that are being sent, even starting walking groups during work, during shifts, getting outside, getting out of the building. So that has people talking about the positive impact of just getting out of the facility on breaks. And there was another question and a comment from Pat Grimes around how innovation could be used to navigate trauma, especially for nursing students, novice nurses, people who are new to the profession. How do we protect those, people who are new to the profession, and just coming at this through an innovation lens, thinking about how do we use those principles of innovation and design to address the workplace, right? So thinking about creating, do we have a culture that is where we have psychological safety in our organizations, where we can bring ideas forward and not feel like we feel like our ideas are valued, that they matter, and that they're going to be acknowledged. And right, not all of our ideas will be acted upon, but you want to know that somebody is listening and hearing that. And thinking about empathy, right? How do we create safety? And how can we make sure that those ideas that are being brought forward, we're working to try them, iterate on them, improve them. I think there's something about actively showing that progress is being made, that we're not being idle, and that we're looking to proactively find solutions. There are a lot of different aspects of this pandemic that are outside of our control. There are some things that we can control, but within those areas that we can control, how can we actively engage in making it as safe and as productive and positive as possible for ourselves and the people around us.
I especially appreciate your comment about younger nurses just coming into the profession, or student nurses, that everything we've been talking about tonight needs to be integrated into nursing programs, not just a quick run through on grief and trauma, the psychological effects of both, and their responsibility as a nurse to those processes, but also what it means to their own process. In other words, I would see it as a way of hopefully inoculating young nurses in, how do you take care of yourself, given that this is part of our practice. And right now it's a huge part of many of our practices.
And fortunately, younger nurses have been slightly more likely to seek professional mental health support. We do have that data backed there. And so that is on trend with the broader Gen Z, even non-nursing population. I don't know, Megan, you may understand that better than I do, but I think that is an area, and I think a lot of, or more younger nurses, however, did say that they were less likely to know where to find the resources. And so I've seen many comments in the chat about mentorship, and I think that really is where more experienced nurses can be passing that information on about where can you go to get that support that you so need.
And comments in the chat about the importance of mentorship and organizational mentors and, having people who can help inspire and be a support to people within their facilities. How would you, with that, and people are talking about different mentorship programs that they're utilizing. Any advice for people who are in leadership positions or in whether it's a formal or informal role or titled? I think all nurses are leaders, no matter their title. But how can mentors prepare themselves? People who are in those positions. What's unique? What unique things should those people be thinking about if they find themselves in those roles?
I think in terms of mentoring younger nurses, that saying, eating our young, is still out there and still being circulated around. I don't know how much of that is still happening, or if that's just kind of this meme that keeps going, but I hope we're not still at that place. But I think not to be too quick to judge a younger nurse, and to cut them some slack and kind of, put an arm around them while they're learning. Not that we can let them make mistakes that are going to have an impact on the patient, but they need their time to learn and get their feet under them clinically. And I think mentoring with a nurse with more experience is a wonderful way to do that. And you're always going to have the person on a unit who's got that kind of backbiting, gossiping thing going. And we need to nip that in the bud as well. In other words, the norms of our unit, whatever unit that is, does not tolerate that behavior. So we have to create the emotional, psychological safety for younger nurses to learn and grow. And especially now when they've just got to be so overwhelmed. I mean, the long-standing experienced nurse is overwhelmed. I can't imagine how that is for younger nurses. Could we put the slide up, Ori, the finding balance slide up for just a second?
Yep, give me 2 blinks.
Yeah, I really like what Pat just said. No more backbiting. We must embrace emotional intelligence. Yep. Yes, and yes, and social intelligence. Huh? So it's just that one, the last one, Ori. There we go. I just wanted to mention this slide and throw out a challenge to you, everybody listening. And you could apply this to your nursing staff as well if you're in management, or a group of nurses could put this model up in the break room. Not that you're having a lot of time to hang out there right now, but that you set at least 2 measurable and specific goals in each of these areas, including the spiritual, that you can accomplish this week. And that you set your sights on doing that every week and then every day. In other words, when you consciously ask yourself, what are the ways that I can take care of myself emotionally today at work? It might be avoiding the negative person. It might be, like Ori mentioned, going for a walk with a peer friend and just doing some of that emotional downloading. So to set very specific and measurable goals, so you move toward that. Once we set a goal, the whole field of psycho-cybernetics is based upon this, that when you set a goal and have that intention, that your brain will find a way to get you there.